Good morning, good afternoon, good evening from wherever you're joining us from. Welcome to this webinar that will focus on NCDs, an urgent call for primary healthcare system strengthening in sub-Saharan Africa. My name is Valentine Kamau from Africa Health Business. At this time, allow me to highlight some guidelines for the session. We request all to observe the allocated time and the session will last for 90 minutes. Please feel free to post your questions in the Q&A section at any time during the session and they will be responded to as much as possible. There will be pop-up polls as the webinar progresses and participants are encouraged to tweet during this session using the hashtag AHBS2021. To highlight the session agenda, we will have 7 experts who will be speaking during this webinar. We will have a welcome address from AHB, a moderator from Merck Group, and experts from Kenya Red Cross Society, AstraZeneca, Medtronic Labs, Usizo Advisory Solutions, and Novo Nordisk Middle Africa. And now, let me introduce Dr. Amit N. Thaka, who will give the welcoming address and introduce the moderator of the day. Dr. Thaka is the president of Africa Healthcare Federation and the executive chairman of Africa Health Business. Over to you, Amit.
Thank you, Valentine. Thank you, panelists. And thank you all the health experts that have joined us on the panel, plus all the attendees from different parts of Africa and outside. It's quite amazing. From 2019, when we met in Addis Ababa, everything just changed. And when we met as a board, we felt we needed to keep connected with the leaders in the healthcare industry. We quickly forged a webinar series that touched on everything from COVID-19 vaccines to immunization, to healthcare financing, to partnerships, to Ministry of Health insights, and now NCDs. Through the 3 different groups of webinar series for the last 18 months, we have kept the stakeholder engagement alive with champions like yourselves across Africa. Today marks the ultimate webinar series, which just happens to coincide when curfew was lifted in a country like Kenya. We will move to a newfound hybrid stakeholder engagement to help us get better healthcare in Africa starting February 2022, where I hope we will find many of you attending our event in Nairobi themed Africa Women's Health Day. Today at NCD being the central topic, I'm delighted that we have a great team and a great panel that will give us insights on what may have been forgotten and what COVID may have displaced and how we'll need to build back better our health systems. Africa Health Business, as you can see, does all these work around our services. And today we are focusing a lot on network facilitation. And that's why we have this series. Let me go to the next slide. And we, at this point, would like to move quickly into the series. And I would like you to have a watch at this spotlight video before I introduce the moderator. Go ahead and play the spotlight video for us.
This is life. A moment of joy. Dream come true. All pure love. A tiny breakthrough. Maybe a triumph. A constant struggle. A clash of ideas. Make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we?
Thank you so much. Let me thank Merck as a great partner for many, many years in the African healthcare scene. Karim Bendaho today is our moderator, who heads up the African Bureau and coordinates Merck's corporate strategic and executive decisions in Africa. He's been a real pioneer, met him at many functions at the Africa leadership meetings in Addis many, many times, other regions of Africa. He's passionate about Africa and he's committed to help the continent drive forward. He's a member of different pharma associations. Let me name just a few. The Pharma Research and Manufacturers of America. He's also LEEM, Les Enterprise the Medicament. He's also in the GEIP. He's also a member of CEFIRE, and he's the Africa Engagement Committee Chair of IFPMA, which is International Federation of Pharmaceutical Manufacturers and Associations. It is a great delight that he will take over the discussions and moderate the session over. Karim, the stage is yours. I welcome you to take over this ultimate webinar of HBS. Thank you so much.
Thank you, Amit. I wouldn't expect such an introduction, but thank you very much. Indeed, I'm passionate about Africa. And I would like to thank all the attendees and participants. You know, there are more than 130, now 130 people. And it's I'm really impressed, and thank you very much for taking a bit of time to discuss and to listen our panelists. The movement toward universal health coverage is now one of the most prominent global health policies. According to the United Nations Sustainable Development Goals, all UN member states have agreed to try to achieve universal health coverage by 2030. Emphasis should be placed on the role of the primary healthcare in achieving universal health coverage. The health for all is absolutely indispensable, and which must be integrated into an overall framework for organizing and delivering care based on a patient-centered, efficient, fair, cost-effective way. Today we have 5 panelists, and I will ask them to introduce themselves. Jacqueline, if we can start with you.
Right, good. Thank you very much, Dr. Karim, and good afternoon, my fellow panelists. Good afternoon, participants. I'm delighted to be here. My name is Jacqueline Kitulu. I am a general practitioner, family physician, practicing in private practice for more than 20 years now. I am the first deputy governor of the Kenya Red Cross Society. I'm the immediate past president of the Kenya Medical Association, which is the umbrella association for doctors in Kenya. And I sit on various boards in the health sector. I sit on Kenya's National Hospital Insurance Fund Board, the Kenya Medical Practitioners and Dentists Council, which is the regulatory body. I sit on the boards of Path Kenya and the Safaricom Health Advisory Body, TC Field 4A, Bionate, amongst others, and very delighted to be here in this engagement on primary health care systems strengthening as I work in primary health care. Thank you.
Yeah, you are on the field. Mr. I will let you introduce yourself. Maybe we move to Eric, waiting for
Can you hear me? Can you hear me all?
Yes. Good.
Okay.
Fantastic.
So, good afternoon, everyone. It's a pleasure to be on this platform discussing a very pertinent issue around the non-communicable disease. I'm into the healthcare for almost 20 years, having worked in self-paid, non-reimbursed geographies like India, have experience, in Europe as well as Middle East, and now in Africa for almost last 5.5, 6 years. So It's a real pleasure to be a part of this August forum, I would say, together with other fellow panelists, and looking forward to a great discussion. Thank you so much.
Thank you, Arpin. Thank you very much for the introduction. And Eric, it's over to you.
Yeah, thanks, Karim. Good morning, good afternoon, good evening, everyone. My name is Eric Angula, and I work with an organization known as Medtronic Labs, which essentially is a social enterprise organization that is focusing towards providing access to underserved patient populations, especially those living with NCDs. And in Medtronic Labs today, I lead strategic partnerships and government relations. I've been working with Medtronic Labs for a while now in a career that transcends both commercial as well as also being able to build alliances for impact. And I also sit in the board of NCD Alliance of Kenya and also the Children's Sickle Cell Foundation. Really excited to be here and looking forward to the discussion. Thank you.
Thank you very much. Dr. Anushka, if you are online.
Hi, good afternoon. Thank you, Karim, and thank you to the Africa Health for having me on this esteemed panel. I am a medical doctor and health economist from South Africa. I headed up the KPMG Healthcare and Life Sciences practice for about 8 years. I have since established my own independent healthcare advisory practice, and we do strategy, market research, leadership training, and wellness development for a number of clients. Recent clients that we've worked with include the WHO, the government employee medical schemes, and a number of other clients like the IFC. So I look forward to the discussion this afternoon. Thank you, Karim.
Thank you very much, Anushka. And last but not least, Vinay.
Thank you, Karim, and a very good day to my fellow panelists. Good day, everyone. A pleasure to be part of this amazing platform. My name is Vinay Ransiwal. I am the Vice President and General Manager for Novo Nordisk in Middle Africa, so which is actually 49 countries, Sub-Sahara except South Africa. I have been, my profile is similar to Arpit. I've been in this industry for almost 22 years. Born and brought up in Novo Nordisk, only company I've worked with, and I'm still learning. I've been working in India, in Latin America, various geographies, and for the last 3 years in this amazing setting in Africa. I'm really looking forward to this discussion and looking forward to hearing from all of you. Thank you so much.
Thank you very much. So as you may notice, I mean, expert from the field, expert from the private sector, expert from NGOs. So I'm sure that let's start with Dr. Jacqueline. Jacqueline, can you talk to us about your clinical practice experience with regard to NCDs?
So thank you very much, Dr. Karim. Even as I was preparing for this, I wondered, how do I take this on? And I decided perhaps the best way to share my clinical practice is to share some cases that I have engaged in, memorable cases in the area of NCDs. So I'll give you 3 cases of my patients, and which will reflect part of my engagement. I mean, there's a lot more I could say, but let's focus on these 3. So the first case is Mr. FW. He's now 80 years old. He's a retired businessman, so someone in the upper middle income bracket, who first presented to me 20 years ago. And he came to me as a chance, one of those chance patients. He had applied for to join an insurance company. And when they did a medical, they told him, you have a very severe high blood pressure. You need to see a doctor. So he had never really seen anyone. I mean, as many men generally don't go to see doctors unless there's a crisis. So very pleasant man. He came in at that point about 60 years old. And basically, he had a blood pressure of 220 over 120 millimeters of mercury. The other vitals were well within normal, but also very interesting is that he was a heavy smoker. And he told me he started smoking at age 16 years. And he was basically smoking like about a pack to a pack and a half per day. So he's one of my patients who we went through the conversation on hypertension and the complications of hypertension, what smoking does to complicate that. And I must say he's been one of my most adherent patients to treatment. However, he always told me on the subject of smoking, we shall not discuss that. He says, I've been smoking and I will not stop smoking. So he said, I will follow any treatment. And we did all the necessary investigations and everything. Blood pressure is well controlled, but continued to smoke. Fast forward 5 years ago, difficulty in breathing, breathlessness, and dyspnea on exertion, and eventually diagnosis of COPD. So this hypertensive of those many years, now well controlled, suffered now the complications of that chronic smoke, long-term smoking. So finally, 2 years ago, he stopped smoking. But he stopped smoking, our blood pressure is well controlled, but he has severe COPD on all sorts of inhalers and quite limited activity. That is patient number one. Patient number two, young man, Mr. AO. Okay, coincidentally, I've talked about men, but anyway, so young man, Mr. AO, 40 years. So 40 years is, I think when I was in my 20s, I thought 40 was very old, but now 40 years is relatively young. So a security guard, so married, but living on his own because of his work, and uninsured, basically no insurance at all and paying out of pocket. And he came in with a history of just severe fatigue and loss of weight and just not feeling well. And so in a basic examination, significantly, he had a blood sugar of 22.4. Normal blood pressure, BMI 19, almost underweight, no family history of diabetes, very poor diet. Remember, he lives on his own, works at night. And here I was with this man who his family depend on him for his work, and yet newly diagnosed diabetic, needing insulin. So even just the hurdle of even understanding what is this diabetes and accepting what it is, affording the treatment here. I mean, this is someone clearly who needed to go straight onto insulin. Where can we find insulin for him to be, how does he get to afford that in terms of also testing and monitoring his sugars? Quite a whole lot of issues then pop up. That's patient number two. Patient number three, the last one, a young girl, 14 years old. She came in for a routine medical exam, joining secondary school, going to Form 1, and most schools require a medical examination. And this young lady, no significant medical history, but she came in with her father, and the father, and coincidentally, running a family practice, you find that you know relatives. So the grandmother of this girl is diabetic hypertensive. So anyway, this young lady, we do the physical exam, nothing extraordinary, and then the basic tests required for the medical exam included a blood sugar, and her blood sugar was 25 millimoles per liter. So, once I saw that, I went back to, okay, anything else? And interesting, she says, actually, the last 3 months, I've been very hungry. I'm constantly eating and, and yet I'm not gaining weight. And I thought it's because, I finished primary school and I'm at home. And so, clearly a diabetic. And then what are the protocols then for a pediatric diabetes? Because with a 14-year-old, essentially with the protocols we have here, it should be managed by a pediatric diabetologist, though this is right within the primary healthcare area. So again, here's a young girl supposed to be going to a boarding school, newly diagnosed diabetic. There's the issue of the diabetic education, the management, the further investigations to be followed up. All three cases, which I'm sure can be seen in any primary healthcare system. And as I've put various, just for us to see that, it can be upper middle class, can be lower, can be children, all presenting with the NCDs. And the reason I brought these out is, and perhaps which my other fellow panelists will then perhaps feed into, is in relation to, in terms of strengthening the primary healthcare system, some of the issues that then arise in terms of how strong are we in terms of public health education and communication on some of these preventable diseases, on the risk factors. The cost of monitoring or screening for some of these diseases. For the older two cases that I gave, I mean, they had, that old man was probably hypertensive all those many years, but had never been screened. For the second one who's now newly diabetic, the monitoring, how is he going to afford that? What are the systems that are in place for someone like that? The costs of medication. So all these, I mean, the ones who have to go on insulin. Yes, in the past, people had injection, it would inject insulin, but even with the insulin, you're saying, okay, does he have a refrigerator to keep his insulin? If he has a pen, how will he afford that? So all the issues of costs of medication, how do you get good treatment if the cost is unaffordable for someone who is uninsured? And then the cost of investigations, the cost of management. All these come out in these three cases and are critical areas that UHC should address. We hope UHC should be able to address within the primary healthcare setting. Thank you, Karim.
Thank you very much, Jackie. This is three very important questions. I mean, public health education, screening, and monitoring. How maybe some of our panelists here can answer some of your questions. First of all, do we have a question from the participants, the attendees? No. Arpit, what is the role of the AstraZeneca that AstraZeneca is playing in health system strengthening?
Yeah, so I would like to put up some slides.
This is for scientists and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown. Fueled by imagination, alone and with others. Repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science in everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease, the best way to change people's lives. This is why we believe in what science can do.
Yeah, so from my side, I would say if you look at AstraZeneca, I think our portfolio fits in very well with what is the need for sub-Saharan Africa. So I would obviously like to highlight what we are doing in the respiratory space with our big Pumua initiative. We all know in Swahili, Pum means breathing. So Pumua is like to breathe. So if we continue with our slides, please. I mean, we all know the burden of NCDs. I would not talk about the statistics here. We have all clearly, we are aware. And obviously, if we look at the economic burden as well, it's quite huge. Going forward, if we look at how the NCD burden is, across the geographies, if we go to the next slide, we clearly know that Sub-Saharan Africa as a geography has a higher burden when it comes to the NCDs. Can we go to the next slide, please? Yes, we all know 77% of the all NCD deaths are in low and middle income countries. Same happens true for the 85% of the death among the people under 70 and obviously asthma related deaths. So going forward to the next slide, if we look at AstraZeneca's portfolio, if you look at bullet number 2, we have portfolio around oncology, around new advancement into the CBRM, respiratory and immunology. So I think which is a great opportunity for us, given that our portfolio fits in very nicely what we can contribute into the NCD space. And at the same point of time, how we are looking at it within AstraZeneca is not only serving the continent with the products, but what we are also serving the continent is how can we bring some sustainable programs to focus on some of the key challenges which sub-Saharan Africa faces. So if you can go to the next slide, please, I would like to highlight what AstraZeneca is doing in this space. So if you look at what are we trying to bring on the table is making our medicines more available and affordable, which obviously is our contribution towards the NCDs, supporting health system infrastructure. This is a big ask. So we are basically working in partnerships with the governments as well as with the other stakeholders, and also promoting the disease awareness and prevention. Without going into the detail, as I said, I mean, at this stage, we are embarking we have embarked on this initiative almost 9 months down the line, where under the PUMA initiative, we are building the overall infrastructure within sub-Saharan Africa markets by putting across the nebulization stations and also bringing the knowledge at the primary healthcare physicians level. How can they really treat the acute asthma pretty well? Young Health Program is a program where we are basically looking at educating the youth in some of the geographies in Kenya, for example, either if we look at Kibera or Matare, and we are educating them on what are the disadvantages of some of the habits. How can we help them to, to some sort of a walking away from the smoking and other habits and have a healthy youth, also working in very close collaboration with Plan International. Healthy Heart Africa, can we go to the next slide? Healthy Heart Africa is also our initiative where we have worked very closely in terms of bringing our cardiovascular products at a highly affordable prices and made a big impact in terms of the number of doses which we have provided. So just a quick 1 minute snapshot on the Young Health Program. I would like to bring your attention on the last bullet. If we see YHP has reached more than 3 million young people and we have trained more than 50,000 young peer educators. This is something very, very powerful. And I would say from sub-Saharan Africa, Kenya happens to be our primary place where we are quite active on the Young Health Program. Going on to the next slide, please. Yes. Again, Healthy Heart Africa, quite a lot of statistics here, but I would like to bring your attention. We have been present with Healthy Heart Africa into highlighted countries, what we see here on the slide, with Kenya, Ethiopia, Tanzania, Ghana, and we are adding more and more countries. And if you see, the statistics are quite impactful, almost 13.5 million screenings. We are talking about 2.4 million patients identified living with high blood pressure. And obviously what we are also complementing this is providing healthcare worker training and access to the low-cost medications. And as I'm talking to you, we are constantly expanding our Healthy Heart Africa initiative across fewer geographies into sub-Saharan Africa. Can we go to the next slide, please? Again, I would not go into the details, but the usage of the biofuels around the Dunga beach is something we have realized.
Arpit, your voice is a bit low. If you can get closer, I don't know.
Is it better now?
Oh yeah.
Is it better now?
Great.
Yeah. So again, I would like to highlight the Dunga Beach project where we are working with the communities to minimize the impact which is happening out of the biofuel, and again, working on the respiratory healthcare to bring the training, disease awareness. So just wanted to highlight that as one of the key initiatives. And if you go to the last slide, the next slide, please. This is the PUMUA initiative where we are very closely working with the governments on strengthening the local health system together with the capacity building and education. And in the end, also bringing our medications at a, I would say, equitable at the same point of time, highly subsidized prices. So at this stage, we are quite active in terms of the cardiovascular space with Healthy Heart Africa program. Respiratory initiative is quite big for us. And in addition to that, YHP. So I really feel proud at this stage with these programs, what we are bringing into this geography, that we are significantly contributing towards this challenge of NCDs into sub-Saharan Africa. Could we go to the next slide, please? Yeah, just some of the glimpses. I would not go into the details in terms of how we are bringing these nebulization stations and making the physicians to be very much empowered in terms of making sure that they can make their asthma, they can do a respectful treatment to the acute asthma patient. Otherwise, some of the public facilities, they would potentially not have a place. So in the end, I would say is this is the beginning for us. If you look at the respiratory space, and we continue to make our medications more affordable, continue to work with the governments on the capacity build and to contribute to the NCD environment. Over to you, Dr. Karim.
Oh, thank you very much, Harpi. Quite impressive programs in terms of awareness, in terms of monitoring, and in terms of support. By the way, you have the questionnaire here. If you can answer to it. Let's up. And I have a question for you, Ahmed.
Sure.
Are you able to? This is a difficult question because I'm facing it. Are you able to monitor and to assess, evaluate the impact of all what you are doing on the population? I mean, how many people you have been able to reach out? I mean, to support, to help, to educate. Do you have any kind of monitoring on that? And do you see progress over time on this?
Yeah, that's a very good question. I think monitoring is very, very important so that it continues to give us the feedback and the motivation going forward. I mean, we have statistics, if you would have seen around the Young Health Program as well as the Healthy Heart Africa, how many patients we have, diagnosed, how many patients we have in a way, supported in terms of the YHP. If you look at the PUMUA or the respiratory initiative at this stage, we are quite early into the stage, but obviously we believe in having shared accountability with the stakeholders so that we are able to see what is the impact we are making in terms of more patients being diagnosed, what is the impact we are creating in terms of more lives treated. At the same point of time, sometimes it can be a challenge as well. So for me, I would say very, very important that we continue to measure. And that also helps us to do some sort of course correction in the middle if there is something which we need to adapt or change into our program. So my final submission would be yes, we do focus on the metrics. We do focus on the joint KPIs when we work with various stakeholders. There are cases where we have very clear measurement. There could be situations where it becomes a bit hazy, and I think then we come back on the table and discuss with the stakeholders. In the end, it's very, very important, as you rightly asked.
That's great. Another question. I mean, I have a lot for you. You know that to achieve UHC 2030, an assessment of the WHO is reflecting that we will need most probably between 10 and 12 million health workers. And most of them in the primary health system. Do you have any program ongoing or coming, to support this capacity advancement which will be required? I mean, to train those health workers.
Yeah. So for me, I would say under the umbrella of our Healthy Heart Africa program, we are already doing the health worker education and capability building, I would say, in a hypertension space. And then the same is happening through PUMUA initiative, where we are working with county hospitals to make sure that the healthcare workers in those facilities are in a way better equipped to identify the respiratory illness and treat it better. So at this stage, these are the two areas where we are focusing. We also have plans to work with some other entities from an awareness point of view, so potentially having some tie-up with companies who provide more awareness. At the same point of time, the in a way disease area / counseling training to the healthcare workers, and that is something which is very much on our cards. I may not be able to comment in terms of how much we would be able to make an impact from a number of healthcare workers, but certainly this is something which is what we are doing, and it is on our cards.
Yeah, I think it's part of our duty as a private sector, and I can only congratulate you for that. We have a question from Nelly Ali on the. She's saying that there is immense potential that no pharma company has tapped into. The community health workers who are critical, trusted educators in the communities. I'm working with the counties who are keen to add this component by equipping with glucometers and BP machines. Why is the pharma industry not keen on investing in strong community-based primary health care system? I would be happy to work with those interested.
Yeah, so my comment to Nelly would be, I mean, in the end, we are doing our contribution at this stage with our focus on the respiratory disease, as I mentioned. Our objective is to put across almost 1,000 nebulization machines across, the clinics or the centers which we are working with the ministries of health in sub-Saharan Africa. So, I mean, at this stage, as I said, we are doing the needful on the respiratory space. And I believe I would also use this question as a call out to my other industry peers as well, if they would want to take the lead either in terms of the glucometers or the blood pressure machines.
I think this is a very good call, and we should. Thank you, Arpit. Thank you very much.
Thank you.
We don't have any other question. So great, amazing program, and congratulations again. Now, let's move to the next speaker, who is Eric from Medtronics. Do we have a movie to introduce Medtronics, the company?
Medtronic Labs is built upon 5 principles. First, we design with and for the communities to address local barriers across the care continuum. Second, we employ evidence-based practices and protocols for uncompromised clinical excellence. Third, we address the social determinants at the root of poor health. Fourth, we integrate digital and product technologies for high-tech, high-touch models of care. Fifth, we innovate operational models that enable efficiency at scale. Learn more at www.medtronic.com/Medtronic Labs.
Karim,
Sorry, Karim, you're on mute.
Okay, sorry for that. So Eric, I repeat my question again. Do you think that the point of care testing, POCT, will be the mainstream of providing quality primary healthcare in Africa?
Yes, Karim, thanks for that question. And I just want to say that I don't think that it will. It already is, mainstreaming, quality provision of quality healthcare. And most importantly, also, supporting the healthcare needs, specifically at primary healthcare level. And the reason why I'm saying this is POCT, or point of care testing, ideally is a means by which we acquire clinical parameters, where the patient is. So the objective is really to be where the patient is, and be able to do that in a rapid and faster way, with an objective to really be able to provide prompt clinical decisions, but also most importantly to be able to improve clinical outcomes. As Dr. Kitulu had mentioned in the case presentation, part of the challenges for her patients was actually really screening and awareness. And as an organization, really, what we focus on is, being able to utilize the existing primary care networks at community level, at primary healthcare level, to be able to address the issues of, awareness, screening, but also most importantly, to be able to translate that into longitudinal patient management capabilities. Because for chronic diseases like NCDs, it's not just sufficient for us to manage patients, like one point in time. The longitudinal data or management, it really helps us to be able to ensure that we have sufficient information as providers to be able to make a clinical decision. So ideally, where the point of care testing really comes in, and I know this question has been asked by Nelly, is then how do we ensure that a patient doesn't need to travel, to the higher level facilities just to be able to take their blood pressure checks, or a simple thing as just blood glucose check. And if you look at primary healthcare in light of UHC, in terms of being able to provide care and quality care for all, we really then need to start thinking about how do we remove all these barriers that have been affecting our patients in terms of accessing these critical testing capabilities. During COVID, as an organization, part of the work that we do, we have telecounselors that really reach out to patients in remote areas. And one thing that really came out that was, a sad state of affairs is that, patients are traveling long distances just to be able to access a blood pressure check. And then you ask yourself, we have very close, healthcare infrastructure close to the patients, like in the dispensaries, for example, or maybe it could be the health centers. But then why is it that then those critical tools are actually missing, or we don't have them at those particular levels? But even better still, how can we then avail some of these tools at the community level? So essentially in Kenya, that's like level 1. And back to Nelly's question, as an organization, what we have done with partners, and I know you mentioned pharma specifically, why can pharma be able to address this gap that currently exists? And I want to tell you that today, and I'm happy that Vinay and Novo Nordisk team are also here, is that we, as Medtronic Labs, we've entered into a collaboration with Novo Nordisk to be able to ensure that at the lowest levels that patients can actually access a testing kit, supported by the existing infrastructure of community health volunteers, but going slightly further than that to introduce also, within the support groups that we could have at least some level of testing. And we don't want to lose that information, because that information is critical for Dr. Kitulu to be able to see over a period of time how this patient is progressing. And so we leverage on digital health technology to ensure that at that community level, offline, that the CHV can actually support the patient at household level with those, point of care testing, and primarily blood pressure, blood glucose. And that can then translate into a patient's review over a period of time. And we have done this as well also with great success with pharma companies such as, Novartis, and other pharma partners as well, who have seen the benefit of being able to link patients early. And point of care testing, really, if you look at it, and I know Karim, you mentioned this, it's not actually just for screening purposes only, but then we also have aspects of, after screening, then we use that data to link patients to care, which is also a very, very critical aspect. But then after we link the patient to care, then how do we, over a period of time, then still use the same resources to monitor patients, not only at the facility? Remember, point of care testing needs to be used advantageously to be able to also decongest our high-level facilities, our referral facilities. Why should a patient travel to a level 5 facility just because they want to do their blood sugars? It doesn't make sense at all. It only serves to increase the cost and the burden of healthcare systems. But then also from the patient side, it only contributes towards lack of adherence and compliance in terms of a patient cannot travel, spend maybe $10 because they want to do a test. They would rather keep that money and buy medication at the local pharmacy, right? But we want patients to use, to have an informed decision on why actually they're using the drugs that they're using from the results of the point of care testing. And this can be done from community all the way to the health centers at the primary healthcare level. And to address also one of the questions that Nelly asked is the availability of some of these, essential point of care testing and really as a whole, commodities, medicines, and for patients on insulin, things like syringes, for example. And we have also embarked on a partnership with PATH and the National Ministry of Health here in Kenya and Makueni County, just to be able to look at how best we can develop some of these communities from higher level facilities to the lower level. And I would say that, yes, that work is currently ongoing. It's quite exciting because then patients who are hitherto, keeping away from the higher level facilities because of the cost of transport can then now start accessing some of these commodities, can actually have their tests done at the healthcare center level, where then at that particular point, then they can be able to also access their drugs and commodities. And in the work that we are doing currently with the Ministry of Health, really trying to look at building capacity at the community level through the community health volunteers and utilizing that infrastructure and the primary care networks to ensure that, screening linkage to care happens at that particular level, but then also the continuous monitoring and patient management with visibility at the higher levels in case there is a referral that is required. So using the point of care testing for those aspects, I think is very critical. It's happening today. It's not a will question, Karim. It's already happening. And I'm hoping that through this forum and through partnerships and collaborations, then this can be scaled up, because really, if you look at it, this is the only way that we can sufficiently and comfortably say that we are on the route towards achieving UHC. Without that, I think we'll still have the same problems that we have today. So I'll stop at that because I know there's still questions coming, but really looking forward to the dialogue.
In fact, the questions are coming from me because I don't see any question in the Q&A.
Okay.
But I have a question. In fact, I have a dream. You as a company, as a technology company, you have also the survey that you can answer now. You as a technology company, how many parameters can you measure today, and how many parameters can you control as per today and in the very near future? Because today we have the hypertension, blood sugar level, and so on. But what about the rest? Do you have something in the pipeline coming? The most sensors to have really a connected patient?
Yes, thank you so much, Karim. I think that's a very good question. So that we know that we are looking after one single patient, and so we don't want to isolate and say this patient has hypertension, so they should go left. This patient has this, they should go right. But as an organization, of course, again, in the spirit of, the ability to do the first things first and to be able to build that and to, also build acceptance and, to be able to build that positive outcome that then can drive some of these policy changes that needs to be done. Then we started small with the two conditions, hypertension and diabetes. As an organization, we are very, very focused on impact and outcomes of the patient. So in terms of those two disease conditions, we track control rates. And for us to be able to really track control rates, then it's critical that the point of care testing, again, the several touch points that a provider can have with the patient really contributes towards determination of whether a patient is controlled or not controlled from baseline. Yes, today we have paper files, but then it's even much more easier given that we are using digital tools. But it's not only control, but there are so many other aspects that we're looking at, like how many patients are on treatment, how many patients are on, are able to access their drugs, how many of those prescriptions are filled. And that really contributes towards a larger cascade, that informs, the prevalence, but also the impact of the programs. In terms of other disease states, yes, today we are quite advanced in terms of, also developing primary healthcare based, mental health solutions. That would be, a critical add-on, plus also looking at other cardiovascular diseases. And also respiratory conditions is quite within our pipeline. And what we also dream about, Karim, is to have an NCD platform that then it could be modular. And we've started some work with the Ministry of Health here in Kenya, really to start looking at how do we build a modular NCD module that then can support all these disease conditions, leveraging on digital technology. Yeah.
Thank you, Eric. So clearly, technology is progressing. Discoveries are coming one after the others, and we need really also to improve a bit the policies around all this this patient care, and we need also really to, that's typically again another public-private partnership which should be also established and very well understood. Thank you very much, Eric. Let's move now to our next speaker. No movie. Okay. So now our next speaker is Dr. Anushka. Yes. Okay. Dr. Anushka Kovadia. Anushka, what are some of the challenges faced in making sure that the double burden of the NCDs does not cripple the primary health system in Africa? And is there any solution to ensure that NCDs are managed by the 3-4 coming year, 2025, as an example?
Thanks, Karim. I've prepared some slides. Is it possible? Oh, fantastic. Thank you. And thank you for this opportunity to talk to you. I think all of us who have been involved in the front line during the last year have fundamentally understood the importance of strong primary healthcare systems and strong government intervention with robust public healthcare infrastructure. From South Africa, there were some really difficult times over the last year when our healthcare system was almost overwhelmed during the first, second, and third peak. And ultimately, we really understood the fact that you cannot manage everything in hospital. You cannot manage everything using specialist care, and we cannot continue with this fragmented system that has embedded itself in our country. Ultimately, when you look at a lower to middle income country, you are dealing with a situation of limited healthcare resources. What you will have to understand is that you need to optimize the utilization of every single healthcare dollar. And in order to do this, we've got to make sure that patients are seen in the right place, at the right time, by the right healthcare worker at the right cost. Typically, the largest number of patients should be seen at a very early stage in the healthcare continuum of care, so that we actually intervene at a community level to prevent the onset of disease and prevent the progression to complexity. The next level should be managing diseases in a digital platform where we streamline, channel, screen, engage, and connect with individuals before they are sick or at very early stages of disease, or when they require channeling into the various levels in the healthcare system. The next phase is we should manage them on an outpatient basis, trying to ensure they attend chronic clinics rather than the emergency room. But after that, we start entering very complex, expensive levels of care as we move towards casualty, hospital admission, and quaternary services. At these points in the healthcare system, we really are using specialist services, high-end resources, and we really have to ensure that there's been a level of channeling and referral to make sure that the right patient is treated at these higher levels of care. Next slide, please. What we have found is that there are different types of services that are better suited for different types of care. For example, you've got your trauma care, cardiovascular, maternity. Then you have your dental, mental, and then you go into your basic medical care, which need gatekeeper functions. And those are typically the early ends of chronic disease, oncology, palliative care, care for the disabled, and elective care. And ideally, these types of care should be administered in a primary healthcare setting. As we face the dual burden of communicable and non-communicable diseases escalating exponentially in our country, we really need to fortify this frontline service provision. Currently, we've got a lack of effective gatekeeper function. We have a lack of communication, and there are not adequate referral pathways between the different levels of care. Doctors and nurses in the front line are unable to access advice when managing complicated patients. Hence, they have to refer unnecessarily to higher levels of care. Specialists in the higher levels of care often receive patients that shouldn't have been referred, and patients land up in this no man's land where they have to travel great distances, they have to spend their resources, they don't have appropriate information or data accompanying them, and they really have their care being compromised. Next slide, please. Ultimately, when we look at what makes primary healthcare work, it's really the interplay between multiple levels of the healthcare system. Starting out at the very highest level where policy, governance, and leadership needs to be demonstrated. As you move into the actual delivery, you need to have an enabling environment which has robust services related to facilities, human resources, supply chain management, the culture, training and development, and adequate facility management services. Ultimately, if we cannot create an enabling environment, we will continue to place our healthcare workers at risk. Other important parts of this primary healthcare framework involve providing evidence-based clinical pathways, integrated program management, where patients are screened no matter what condition they're coming in to be treated for. In South Africa, we've got one of the largest HIV/AIDS treatment programs in the world, and it was developed and capacitated and rolled out. But the greatest challenge we face is keeping patients in that program and making sure that we are not losing patients to follow up because of challenges that people face with actually accessing care in this disparate, fragmented fashion. Another critical component of this primary healthcare framework is deliberately creating patient engagement channels and community outreach programs. Without tapping into patients as partners, we will never be able to have enough healthcare resources to match the growing demand that we're surrounded by. And then, of course, the last component, which is so important, is monitoring, evaluation, and reporting. Data science has now become a critical component of how we deliver healthcare, and there's no better place to actually tap into the true power of data science than in the primary healthcare environment. Next slide, please. So as we look at potential solutions, we really need to understand that we've got to move away from this complete focus on a curative environment. And we've got to enable prevention and promotion across both the public and the private sector. We've got to tap into community and home-based care and really make patients partners and community carers. We have to understand our patient population a lot better. A diabetic is not the same as another diabetic. A hypertensive is not the same as another hypertensive. We've got to start stratifying and managing our patients according to profile and risk. We have to understand how to channel patients along centralized and localized clinical services and make sure that our clinical pathways are supported by evidence-based medicine. Without workforce, there can be no healthcare. So it's really time that the healthcare systems we work in catch up with workforce services that we see in other sectors. We have to invest in our workforce. We have to develop them. We've got to train them, and we've got to invest in their motivation and engagement. And then lastly, we need to understand how to build out our healthcare ecosystem so that the hospital is a hub, but it's surrounded by an entire system. Thanks very much, Kareem. That's all from my side.
Thank you very much. Very, very insightful indeed. Do we have any question? Let me just check. How can we have the presentation of the panelists? I will let the organization answer. Really, Anushka, very, very useful, and so explaining also some bottlenecks and some lack of efficiency of our health systems in Africa. From my side, really, I don't have any other question, unless there is something. No, nothing from the participant and the attendees. So we can move now to Vinay.
Thank you so much, Karim. I hope you can hear me.
Oh, very well.
Thank you so much. And it has been a privilege to be listening. I think it's so insightful. And I thank you, Dr. Jackie, Dr. Anushka, for setting such nice tone. Arpit, Eric, absolutely. It feels like I think already the work is done. I just need to just share a few insights based on and just build on that. No. I just wanted to.
Vinay, you're the last one, so you are the lucky one. They have set the scene for you. But I have a very, very precise question for you. What strategies, can the private sector and mainly your company adopt to improve NCD's care in Africa?
Thank you for that, Karim. And I'll just try to address that briefly in my presentation. And even before I start, I think also to respond to Nelly's very pertinent comments. Thank you for that, Nelly. And Eric answered partly that, and the answer is yes. I think the opportunity is immense. And I think we are also looking forward to like-minded partners in how we can support, how we can do more. And in terms of capacity building, whatever we do is less. I think this is where we also look forward to more and more ideas, opportunities to work and partner. So let me just start by, if I go to the next slide, let me just start by sharing that today, or this is 2021, we mark the 100-year anniversary of the life-saving medicine. And as Dr. Jackie mentioned, these 3 examples, okay? And there's so many more examples where lives have literally changed. And if you go to the next one, and this was a first example where Leonard Thompson, 14-year-old boy, I think he was the first recipient of insulin. And since then, I think Dr. Jackie, Dr. Anushka, all the clinicians who are supporting the patients, they can see, they can vouch that it has made a difference. And if you can see from the graph, life expectancy for people with diabetes has increased dramatically. So I think this is just to set the tone for the discussion. And if you go to the next, even after 100 years, I think still if you look at these numbers, there's so many. And Arpit briefly mentioned about these numbers. There's so many. And these numbers, 19 million, there are 3 of those examples that Dr. Jackie mentioned. There are 19 million lives there. And out of that, if you say the statistics, 6 out of 10 don't even know that they have diabetes, specifically in this area of NCDs. And even those who know they have diabetes, only less than half are being properly treated, okay, that they're receiving the treatment that they need. So there's so much that we can do. And if you look at the key areas of where we work together in terms of improving access is first and foremost, as every speaker has mentioned, and we have seen on the comments from the panelists and from the audience, that there are so many barriers to quality healthcare, especially in terms of quality diabetes care, in terms of capacity. There are affordability challenges that we could also hear. There are also challenges of fragmented supply chain, and there are challenges of education and awareness in terms of giving the right kind of solutions to all the people who need answers for their diabetes. If you go to the next. And before going forward, just to briefly introduce Novo Nordisk, what we are doing. So we are a global healthcare company which was founded in 1923. We are headquartered in Denmark, and our purpose is to help drive change to defeat diabetes and other serious chronic disorders such as obesity, rare blood, and endocrine disorders. And we believe, I think we can only do it in partnerships, and that has been our core focus, that can we strengthen, can we develop partnerships in terms of helping more and more people across the 80 countries where we have our base, more than 169 countries where we have our products available, and through more than 45,000 of our colleagues across the globe who are on this mission. And if you go to the next, closer home, Novo Nordisk Middle Africa. If you go to the next slide, please. What we call Novo Nordisk Middle Africa is 49 countries sub-Sahara except South Africa. And we are 3 units, headquartered into 3 units, as well as we have 100 of passionate colleagues. Many of them have joined this webinar and are listening. And we are all focused on making a difference to these 2 key numbers. 19 million people with diabetes, only 0.6 million are receiving the help that they need from our side. And we believe, and based on a lot of stakeholder feedback, consultation, we believe the key barriers to improving access to care across our geography is in these 4 elements: capacity, affordability, empowerment, and reach. And that I'll just like to briefly share about a framework of making a change, improving access, what we call iCare. And if you go to the next one. And this strategy of iCare actually takes origin from our global social responsibility strategy of supporting driving change to defeat diabetes. And I think I already said earlier, the most important is in terms of accelerating prevention to bend the curve. Okay, the numbers are immense. They will keep on increasing if you don't do something on prevention now. Second, more important is providing access to affordable care, especially for the vulnerable patients in every country. I think they need our help the most, and we need to create some support system. I like what Dr. Anushka mentioned about creating an ecosystem of care for every vulnerable patient across every country. And we keep continuing to invest in innovation to improve lives, bringing scientific breakthroughs to make a difference for people with diabetes. And if you go to the next. And as I said, based on the feedback from all our stakeholders across, listening to them, we said, okay, this is one framework of care that we need to work together to make a difference and improve access to care. So we believe that together with all our partners, if we can work with a framework of iCare, we call it iCare to defeat diabetes, where I stands for each individual patient. We talked of 19 million patients, what we can do. And I also stands for each and every of one of us, what we can do in our area of influence to make that change happen. And the care framework represents, first is capacity, which is, as we have been discussing, increasing treatment capacity, increasing capacity of the system to provide right kind of treatment, and especially in the primary care. Second, also linked to that, is creating ecosystem of care in terms of affordable solutions, especially prioritizing the vulnerable populations that need our help. Expanding reach to more and more people with diabetes across by streamlining, simplifying supply chain, and also finally also working with like-minded partners to create sort of empowerment solutions for awareness and education for diabetes care. If you go to the next. And we believe the key word here is, again, I think the key word, if one take home from this is, this challenge is so huge. I think that we believe that we can do this in partnership and prioritizing the improving access to affordable insulin for vulnerable patients across diabetes. in Middle Africa. And for that, one specific area that we are working on creating is called affordability plans. So these are specific plans that have been created for 7 key markets where we are supporting the vulnerable populations, whether it is the elderly who need affordable medicines, the patients who are uninsured who need our help. And I'll also talk in the next slide. If I go to the next slide, especially a very vulnerable population, even more vulnerable. We talk of 19 million people with diabetes, pandemic of diabetes, in that we forget this small group. Dr. Jackie mentioned about 14-year-old girl. So these are children with diabetes, and specifically when they are from low socioeconomic setting, it becomes even more chronic. So this is where we have initiated a program which is already more than 10 years, called Changing Diabetes in Children, with a call that no child should die from diabetes. So this program aims to provide free comprehensive diabetes care to poor children across 14 countries. And I'm very happy that 10 of those 14 countries are in Middle Africa in our geography. You see, we are reaching almost 30,000 children with this comprehensive diabetes care. Out of that, more than 20,000 are in Middle Africa. And our goal is that together we want to reach out to more than 100,000 such children by 2030. And in that, talking of primary care, what we can do in terms of creating that capacity in the system. 150,000 patient education sessions that have happened. Most importantly, these 222 clinics which have been set across these 14 countries. And there, these clinics basically ensure coverage in rural and remote areas in these 14 countries. So we're also trying to see where the care is needed, if we can build that capacity, build that infrastructure in the system. We have supported training of 13,000 healthcare professionals, basically in primary care, and also in terms of support, free donation of insulin for almost like 2.6 million vials to support the care for these children. If you go to the next one. And for capacity, which is a main discussion point here, and again to Nelly's point and the good comments made by other panelists, that we are looking in terms of how we can together bridge the healthcare professionals' knowledge gap through capacity initiatives. So that we are working on creating some sort of basic platforms that can help. We can support the system to develop the capacity. One is an online portal called Diab Africa. This is an online platform, learning platform available for all cadres of HCPs. Then we also have an initiative called Buddy Doctor Initiative. So this was a mentor-mentee initiative which we have working on. Now we are expanding that with the virtual element of that. The third is a main initiative called Lead Africa. This is in collaboration with our partners in Leicester Diabetes Center. And we have created an online modular comprehensive diabetes learning course. And this is where we are already having more than 1,000 people enrolled in terms of our training. We're also looking at creating and supporting subspecialty training in diabetology. So just to give an example, a few examples, Karim, you mentioned about what can be done. So this is something that we can say we can do much more in terms of building capacity and supporting treatment capacity. And if you go to the next. The IQ journey so far, we have launched the program with a lot of support and encouragement from the various partners, the ministries of health and our implementing partners. Launched the program in Kenya, Sudan, Ghana, Ethiopia, Cote d'Ivoire. And we are looking forward to taking this journey even more. A big thank you to all our partners who have made this success. At least the initiation, the journey is on. And we look forward to strengthening, as we have been talking about, strengthening the capacity in the entire system and what as an organization we can support in bridging that gap. And if you go to the next. And Karim, just to summarize my points, I think in terms of what you said, what can we do in private sector and what we have learned in terms of improving access to or improving or accelerate improvement in NCD care. I believe the key word for us first and foremost is public-private partnership. I think this is a huge task. I think we need to join hands. As many partners, I'm very happy Eric is here. We are looking forward to taking the collaboration forward with Medtronic Labs. We are working with our partners Roche, who are supporting the SMBG part in the Changing Diabetes in Children program. And we are looking forward to more and more partners to join hands together. A 360-degree view, we can be just totally focused on primary care, focus on especially on diabetes, but we also just need to keep a very 360-degree overview of what does it mean in terms of improving access to NCD care across, especially in our sub-Saharan African setting. So we need to take a very holistic approach. It's not just one part, it is the whole system in terms of creating that ecosystem of care. And finally, I'll just leave, most of these initiatives actually, they are initially success, but we need to build a very strong sustainability element to whatever we do together in terms of creating a sustainable long-term impact for all the patients whom we can support in the long term. So I think that will be a brief overview from my side, Karim, and thank you so much for this opportunity from the AHBS team.
Thank you, Vinay. I think something happened, the last two years. We, the private sector, used to act a bit as competitors, huh? And during this COVID, we have seen how we are able, and when we are able to work hand in hand, how things are progressing fastly and quickly. In 6 months, we have discovered the vaccine, basically, and vaccines. Just because we shared our information, we have opened completely our database to each other, and this really allowed us to be more efficient. And all multinational companies and all pharma companies, I think, are now patient-centered. So the patient is our focus, and I think this is now a great time for us to serve as much as we can those patients. But there is a but. We need also to train the decision maker that they have to invest in health. Again, I have always the same sentence: health is not a cost; it's an investment. We've seen how economies can collapse if we don't invest properly in health. Our role is to make technology progressing and toward to serving the patient appropriately. And during those the speeches of the panelists, none of the panelists, even if they are from different companies, they said all of them said, let's do it together. We have some questions, I think. No. Okay, good. Because I've seen some question. So maybe I can share with you the results of the poll. The survey. Thank you. Okay. Which of the 4 main pillars in primary health care is the best in terms of tackling NCD in sub-Saharan Africa? And surprisingly for me, technology is only 13%. I'm a bit disappointed, but still, community participation being the big, almost the half, representing really the main pillar, the intersectoral coordination, this makes a lot of sense, and the support mechanism, 20%. Second one, generally, what is the most needed to strengthen primary healthcare in Africa? Financial investment. Hello? Financial investments and policy reformation, adaptation. Advanced infrastructure is not required, as a technology is not required. And the health information management, which is the patient data management, I think this is also very, very important part to strengthen primary healthcare. And where can the private sector support be most valuable towards strengthening primary healthcare system in sub-Saharan Africa? Most of the answer are public-private partnership, and I agree on that. Research and development and innovation are almost the same, so it's represent 1/4 together, and the advocacy only 4%. Well, okay, why not? I have no other comment. I have a last question for Jacqueline, if you are still online, Jacqueline.
Yes, I am.
Yes. Having listened to all this, to the rest of the panelists, do you feel more optimistic, I would say, to see the primary healthcare system strengthened and improved, or it's still some words and nothing else?
Indeed, I am actually very optimistic. And I like the poll question you asked, that you just projected the answers, and the last one was talking about public-private partnerships being one of the ways forward. And I'm a strong believer in public-private partnerships in the sense that a lot of the infrastructure, and if you're looking at a country like Kenya, most of the health services are indeed provided in the public sector, but there are many deficiencies. Now, the other challenge, of course, then with NCDs is that these tend to be illnesses where largely are asymptomatic. So even in terms of health-seeking behavior, one's not really going to look for to come necessarily because of a symptom. So then a lot of what has been presented here in terms of innovative models, point of care testing being some of them, availing like insulin to children, all those are ways in which in partnering with the public sector, you increase access to treatment for these NCDs. The point of care testing is so critical, especially all the cases that I presented. You have there the young security guard. I mean, how in terms of him finding time, he works at night. How does he find time to come during the day to be seen? And that's the time he should be resting. Yet, if he had somewhere just nearby where he could have his sugars monitored, his blood pressure taken, and it's something we can liaise, and then you can optimize his treatment. So looking at the referral systems, how do we create them so that within the primary healthcare system that we can create appropriate, protocols of management, supporting, so even the companies like AstraZeneca through training of healthcare workers in terms of clear protocols of how do we manage such a condition at different levels of care. So that in that way, you're enhancing the capacity of the healthcare professionals at whatever level they'll be to serve and optimize the treatment of the patients before them. So I am purely and very optimistic about the success of managing NCDs in Africa with this public-private partnership approach. I think everybody has to contribute to it. This is not the point where we'll say, oh no, that's the fault of the government. They let them deal with it. We all have to come in. Actually, there's one of the questions even there that someone asked about, how are we going to make sure this, some of these become a reality? And affordability being a big issue, that if people can't afford care, they'll never come for care. I mentioned I sit on the board of our National Health Insurance Fund, Hospital Insurance Fund. And one of the ways we are revolutionizing looking at the benefit package is that it's all targeting towards UHC, that we should be able to provide care without, that is needed without financial embarrassment to the patient. So basically, even in that perspective, then you're looking at a focus on primary healthcare. That was never a focus. It was always a hospital, curative, get to the hospital, then we'll deal with you in the hospital. Now focusing like, no, we have to start way before that, in terms of the community participation, the public education, and ensure that people are aware. Then when you can deal with it at that level, then you have fewer complications that cost a lot more to deal with in the hospital setting. So I think all the efforts that are being represented in today's presentation from Novo Nordisk, from Medtronic, AstraZeneca, all will help us achieve that dream. Thank you, Dr. Karim.
Thank you so much for your answer. Eric, you notice that the poll results, the question of related to the main pillars in the primary healthcare, appropriate technology was only representing for the audience 13%. How do you think that for you it's a normal ratio, or maybe there is an under perception of what technology can do?
Yeah, I think, sorry, go on.
Eric, go ahead.
Yeah, Eric.
Yeah, sorry, I just wanted to say that, yes, I think it's still an under perception, because, technology has really served significantly, to one, improve outcomes, but also just to support, clinicians to be able to do their work much better than before. And this is primarily because if you look at, patient files, for example, within the healthcare infrastructure, and being able to print every single time is not sustainable. So why can't we be able to, digitize those and have them in a digital tool that then can be used sustainably over a period of time? Yes, with technology, again, comes in change and mindset change, which is not usually very easy to come by. But I think if ever we are to, manage the cost of healthcare, even at primary healthcare level, then technology is definitely the way to go. Thank you.
Thank you very much. We still have 3 minutes, and we have a honorable guest, who would like to tell us some words. Please, we have the former minister of Namibia. He will now introduce himself if he give us the chance to hear from him. Is he connected? The IT team?
Yes. Dr. Bernard Haufiku, you are now on the panel. If you can hear us, you can unmute and go ahead.
Yeah.
Hi, Amit. Hi, Amit, and good Karim there. Can you all hear me?
Loud and clear.
Yeah, no, thanks very much, really, and my apology, I came on board a little bit later, I was in other commitments. I really liked the discussion. Panelists did a great job. We all know that primary healthcare is really the way and the bedrock for implementation of Sustainable Development Goal 3 on health. I just wanted to mention something that may already have been mentioned, and that is really the issue of capacity on the continent. I appreciate the 4 pillars referred to there in a snapshot of community participations, health financing, etc., which are crucially important. But overall, Africa, and especially sub-Saharan Africa, need to build capacity in all aspects of healthcare delivery. And that is the way we will succeed in implementing and strengthen our primary healthcare. And obviously, the issue of partnership is paramount. No public health system will do it on its own without partnership with the private sector. And we tend to see, like in our setting, that capacity is much better in the private sector than in public. We need to harness that and enhance our processes of reaching care for all that is affordable. It's just that a bit of that remark that I wanted to say. Thank you so much. Over to you.
Thank you so much. Very, 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 very useful. So now we reach the end of our panel, and we are on time. Thanks to all the participants and the attendees, and thanks to the panelists who have been really great and very insightful. And thanks to IHBS for organizing this symposium. See you soon next year, I think, February. And the topic will be women leadership, and we will need millions of women health workers to reach and to achieve this UHC 2030. Thank you so much. See you soon.
Thank you, Mr. Moderator. Thank you, panelists. And we learned really a lot of new stuff. Have a great day. And on behalf of HB, I would really like to thank Karim Bendahu. Wherever you are, give him a round of applause. He did a brilliant job as a moderator, bringing so many of you experts together in one room. And also to all the attendees who've stayed with us right till the end. I'm sure we could go on for another hour. And to the team behind the scenes, thank you all for all your support. Bye for now. Have a great evening, and see you soon.
Thank you.
Thank you.
Thank you. Bye-bye.
Bye.
Bye.